So I'm going to shift now to treatments of comorbidities in ASD. The mainstay of treatment are exactly the same medications as in children with ADHD without ASD. But generally, the rates of response are smaller in children with ADHD and the rates of adverse events higher. And the real trap is the danger of making the child more anxious. And really, the clinician is faced with a decision about which way to go, which is more handicapping to the child, the ADHD symptoms or anxiety. If it's decided to go ahead and treat, I think all experienced clinicians in this area start with very small doses, lower than they would do, typically developing individuals, and just increase the dose slowly, usually to a point where one's got a beneficial effect, and sometimes, if you're feeling brave, just to go a little bit more to see it's too much and drop back down again. But the children do require very regular monitoring for blood pressure, heart rate growth, because these are appetite suppressants and historically were widely abused by often women to keep themselves slim, which is giving me an idea. The good thing about ADHD is that the field is very used to having good schedules for recording pre and post behaviour and side effects. And actually that's something that the ASD field hasn't been terribly good at picking up on, that we ought to be charting more accurately the response of children and adults to these medications. Even if children do respond to stimulants and their impulsivity decreases, their attention improves, motor function may get back down to a normal level, then executive skills don't magically recover. These individuals still need behavioural interventions and really very direct teaching of executive skills. So this is not a universal panacea for all the deficits associated with ADHD. Now, anxiety, as you've probably heard numerous times over the last few days, is by far and away the commonest comorbid condition in ASD, either in childhood or adulthood. And this is the sort of order of priorities that I adopt. First, is there anything I can do by changing the environment that will make the child less anxious? There might be some very trivial shifts, like providing a quiet room at the school that the child can go to when they're overloaded, or making sure that their routine is not inadvertently disrupted. To teach them straightforward relaxation techniques, particularly controlled breathing or imagining relaxing scenes. And then if those simple things don't work, to try CBT. BC, of course, is at a disadvantage in that access to CBT is not as good as in many other parts of the world, and adults in particular can not get CBT for free under health coverage, which is a shame because this is one of the most effective interventions we have. And even if I'm treating someone with medication for anxiety, I still urge them to go and buy a self-help book on CBT if they can't afford to access it themselves. And I point out that really we should be teaching CBT in high school. We would all benefit from knowing some very simple techniques to deal with those moments when our fears overcome us. I still see benzodiazepines being prescribed in adults, and this is really a big no-no unless the individual has catatonia. And the reason is that the body habituates very quickly to benzodiazepines, so the drug really needs to be constantly increased in dose to maintain the same therapeutic effect. And trying to come off benzodiazepines is very difficult. It has to be done very, very slowly, and a lot of unpleasant side effects. The problem is, of course, they're a quick fix. You give someone lorazepam and they feel wonderful, and so it can sometimes be hard to convince patients that this isn't a very sensible route to go down. Nowadays, SSRIs are the mainstay of pharmacological treatment. In most countries, fluoxetine would be the most prevalently used medication in children because of lack of difficulties with side effects, although it can cause arousal and agitation in some children with ASD. But as with the other medications, these drugs increase in effectiveness the further away you are from puberty going into adulthood. Children have more side effects than adults. The different types of SSRI have different side effect profiles, and so, of course, some clinicians will adjust drugs purely to get the lowest adverse effects. In adults, I use escitalopram simply because it's the most potent of the SSRI and has a very good side effect profile.